And so today we have Dr. Jeffrey. She's a Swedish-trained dentist with additional research training in immunobiology and neurobiology. She's currently the director of the Senior Center Geriatric Dental Clinic, where she provides care to low-income elderly. So everyone, please welcome Dr. Jeffrey.
Okay, so how many of you are first year? Okay, that's great. Second, third, fourth, they have already graduated in their minds. And I don't blame them. So I work with the fourth years out at the Senior Center. So that's part of your curricular training. I'm sorry that I will not be able to talk about homeless elderly today, because I will need to talk about the economically challenged elderly, and that's because we don't have, with our outreach, it's hard to reach homeless elderly. They are not drug abusers, mostly like the more adults or normal adults like in our age, or young adults or older. They're more mentally disturbed. So when I talk to the social workers in Snohomish County, where the Senior Center Clinic is, I realized that we have none of them coming to our clinic. And in order to provide any type of dental care where you can see your progress, then it's difficult to work with homeless, because they have a very unstable life. I know now you almost look at me like, what is she saying? But the goal with the program that we have in the fourth year is to give enough of knowledge how you do preventive care so you can actually improve your dental health. And with the seniors that we see in the clinic, we have a harder time than we would think of getting everyone stable and come to the appointment. So we call them like 2 days ahead. We book the appointment, and then we make sure that we call them. We have just as you need to do or needed to do before the patient care providers starting to help you more. But we need to call, and I try never to cancel a clinic. I had personal family emergency, so I needed to cancel one of the clinics. And it creates such a mess because they cannot cope with anything that's changing. So when we provide care to this group of elderly that's very vulnerable, even though they're not homeless, you need to be the stable person in their life. So it's okay to hug people in this clinic. It is okay to touch people and be, in a way, less professional than you are taught to be, just because that's what they need. There are many of the elderly that we see, they haven't been to the dentist for 10, 15 years. Many of them have had very good jobs, and then they retired and they didn't have enough funds to kind of pay for dental care. So many of the patients that we see is very tragic. It could really be us if we didn't have a higher education. It's very, very easy to be needing the type of care that we provide here. So my focus with this clinic and with the talk today is to show you how far you can get with a lot of preventive care. I had a patient in faculty practice right this morning, and she came to me for a second opinion because the previous dentist had told her that she needed a crown on many teeth, like 6, 7, 8, because her teeth were hypersensitive. And since I have been working with the elderly, and I know how important it is to have a preventive care program, I said, no, that's not what I think you need. Why don't you try the Prevident, like 5,000 gel, like toothpaste, and you try Sensodyne or Pronamel, they are equal, and Arm & Hammer with extra calcium and phosphate. And she saw me today, and that was 2 weeks ago, and she said that she got better the next day. She was taking ibuprofen for toothache. So you see the difference when you know something about dental preventive care and you live it out. And you expect your patients to live it out too, because you need to be the care provider. Then they can really see a change. So she saved a couple of thousand just to buy some toothpaste and use it. And then, of course, she needed to cut down on her fruit intake because she was eating so much fruit, and that made her teeth hypersensitive. Okay. So what do we talk about when we talk about elderly? Well, the UN has defined it like starting from 60. So that means that maybe I'm approaching to be an elderly. And I don't feel like that at all. I still feel like 17 plus something. Even though my hair is a bit more gray than on the flyer in the elevator. That was when I came here. But 66 years is what we said for the accreditation because we needed to have a number. It's actually more appropriate to talk about elderly in terms of how vulnerable you are. You know, and you can be challenged by your economy, you can be challenged by disabilities. So they are saying that the number of centenarians will increase tremendously during the next couple of years. So you will see a very different aging group than what I have seen. So this is some of my background. In Sweden, I did oral health assessments. So I have always been combining basic science and histology and oral biology with doing dentistry. So this is what we were a startup company of 7 dental hygienists and 3 dentists from a private clinic that we competed for 330 contracts to nursing homes and assisted living facilities. And we developed a system in which we could assess. And this you can apply in any setting, even for homeless. We could assess 5 to 10 patients per hour. And we developed a program. First, we had this handwritten form, like where we just put in like which teeth were missing, and we checked the boxes and gave healthcare instruction. But then we developed a program on just, this is old-fashioned. This is before 2002. I immigrated in 2002, and life has gone so fast after that. But you could do this on a smartphone now. And you just punch in the boxes, and then it automatically prints out like the care instructions, and you can give it to the patient. That's something easy that you could do if you want to screen a population and actually give them something to take home afterwards. So the oral care Swedish model, I was just with the company for, I think 2 years before I immigrated to the US. So we were assessing nursing home residents, and in Sweden, or in Europe as a whole, I think because more of the way society is structured, it's more a close-knit community, and you don't have the personal freedom that you have here. So that means that they have more systemically or systematically developed products for oral care, for elderly, which would also fit for the homeless group. You have more of chlorhexidine and fluoride combinations, which would decrease bacteria in the oral cavity at the same time as it would protect the teeth, which we don't have here. So what we have here, and it's the same companies that actually make the products in Europe as here, but only the 0.12 oral rinse is what we use here in the US. So in Sweden we have a 2% rinse and a 1% gel. So it's easier to brush with because the gel sticks better. We could potentially, I have a tube here, we could potentially ask the compound pharmacy to make it for us. But I've been thinking about that, but I don't know the price, how high it would be. So what we in the company did, so we were working at the nursing homes, and then we did necessary dentistry. And that would mean cleaning, SRP, extractions, and also the patients that could potentially go outside of the home, we took care of at the private practice so that they would feel much more special. It's harder to treat someone sitting in a chair or laying in a bed. And we also gave oral care education to the caregivers, so lectures in oral hygiene, caries, periodontitis, and oral medicine, and hands-on teaching, like how, because many of them needed to brush their elderly's teeth with an electric toothbrush, and just to make sure that they actually were doing the right thing. We had hands-on demonstrations. So this made the company so successful. So let's see here if I remember. They now have over 500 employees, and it's spread all over Sweden. But I just left and went to the US instead. But so this is the model. I think that you can see that it works. That you can see how you can be efficient without losing your heart. But you can also give something, like in written form, to the patient. And you could potentially do this with homeless when you do screenings, like when you're out and do screenings. If you had this, they could have care instructions and they know like what to buy if they're able to. Anyway, if we look at Washington State Plan on Aging, that is that we are using right now. Goal 3 and 4 are the most important ones, and you can see what will happen during the next years is that many more elderly will remain in their homes, and we need to have evidence-based healthy aging programs. So where we have the mobile clinic right now is actually within the Center for Healthy Aging out in Linwood. And some of you first years have been there. And so we are going in the right direction, but this takes a lot of work and takes a lot of dedication from the social workers that kind of run this, and also for me, just running the dental clinic. So how many elderly do we have if we look at low income? And you can see in every age bracket here, it is about roughly 10% of the population that is living under poverty status or lower. And a couple of years ago, this is from 2013, this is how it would break down. So as a single person, you're at the poverty level if your monthly income is $960 or less for one single person. And then you can see here the breakdown if you're a family. So the grants that we get to run this geriatric clinic at the senior center is based on different percentages of this poverty status. So the patients that come there, they don't pay anything. And the grants pay for my salary, the salary of the DAs, and the material that I buy. And then I budget meticulously so I will not waste like a nickel. Just to be able to give all the preventive care products to everyone. I even give Prevident Gel. It is by prescription, but the school price, if I buy it now here, is $4. And it's nothing, so it's much better that I buy it and give it to them. I even sometimes give antibiotics if I see that they don't have the funds to use it. And I give chlorhexidine if they need. So I buy sometimes personally also like the xylitol chewing gums and things like that, so we have it stocked. And I brought some with me. I go to Walmart and I just buy the good things, and then I know exactly the price so I can tell them. Because Walmart has the lowest prices. So 40 xylitol gums are like $2.96. mean flavor. So this is the program that we are running together, like 4th years and me out at the senior center. We also in the schools do some outreach, and 4 times per year. So I didn't know when I bought my Ford Escape that this would be the main reason I had it. And here you can see I have packed it. This was actually 3 units, but it was a bit too much packed. So I made a deal with the students that I took the dental carts and they took the chairs, I took the air compressor, and then we kind of divided it up. So when we go down to Longview, not this Saturday though, because since I had some family emergencies, we're actually treating the elderly at the Kaiser Permanente. But otherwise, we set up for the day a clinic at the Longview Housing Authority, just for 1 day. So just so you know that in the school we have that capability. Also for homeless, we can set up clinics, and I know that this is what we used to doing, but we can do it for full treatments. I have 2 air compressors. One is 3-line, one is 2-line. I have 3 units here, and we have the mobile chairs, like the lawn chairs, but they are fine for a day. So we have the capability to do it. This is how the mobile clinic was started. This is out in Everett at the Snohomish Senior Center. We're at the Everett Senior Center at that time. And I almost fainted when I saw the room because it had wall-to-wall carpet. And of course, you have waste bottles because you don't have plumbing. So when we did extractions, we had bloody water just soaking on the wall-to-wall carpet. But that's the scenario that you have. You don't choose the room that you are given. So now we are in a different facility, so that's why I dare to tell you this. But this room was transformed to a mobile clinic. But since the plan for aging also changed, so the senior center got funded for building a new center for healthy living. So we have changed location. But we turned this room into a dental clinic for, let's say, like 24 to 36 weeks per year. So I was carrying things back and forth. And here's what it looked like. You see the wall-to-wall carpet. This was 2012. And the older chairs, and we had 3 different types of carts, or if you dare to call them carts. And we have some single air compressors that really look like tractors, and they sounded like tractors too. But we were able to provide dental care even to COPD patients, as you can see here. And this is how a clinic day could look. Now, we are at the Center for Healthy Living, and see if I'm able to do this. Yeah, you don't hear the sound, do you? Because it's not plugged in. But the seniors here are celebrating Thanksgiving just 2 years ago, and we are there on Fridays. It is the Filipino Day, and they always have music on, and they line dance and they chimney and they do everything. But the dental clinic now is more fashionable. It is inside here. So we are surrounded by an environment where the seniors feel very at home. And here's what it can look like today. So we have brand new chairs with lights. We still have the filing cabinets, that's dental cabinets, because they're actually so good. So I can't justify to pay $500 each for new cabinets, but these are pretty okay. So, and we have changed everything now. We have modified things. We are self-reliant on almost everything, so I can just go out there and we can work. So if you look globally, so what is the goal of elderly health for everyone? Well, WHO has the goal of keeping like 20 teeth per person, like a premolar bite. They say that that's stable enough to be able to chew. And prevention of caries is of course key for this to happen. So if you look at the socioeconomic status when we are low income, very reduced access to care. So the patients that we see, they are not eligible for Apple Health. They are outside the Apple Health system. Many of them are recent immigrants to the US. They come through family connections, or they might own something that kind of disqualify them, but they cannot sell it. So reduced access to care, low self, they are getting more conscious, because since we say that everything mostly is possible that we can do by our own hands, like in the clinic, we can provide fillings. We have done even like Maryland bridges, but homemade. They're actually getting more picky, and I think that's a great thing. What is important, because I know everyone wants dentures, partial dentures or complete dentures. What is most important for the partial denture is that you cannot just do it and then call it a day, because many of the patients that we see, they come in with multiple caries teeth or retainable tips, and there's a reason they look like that. And we need to be able to change their behavior. It sounds really bad when I say it, but just change how they take care of themselves. Otherwise, what will happen is that they will lose more teeth just within the next year. So at the senior center, now we're actually, after having it for, I've been running it for almost 4 years now, then now we are starting to do more partial dentures and see how we can fund it, because now most patients are at the point where we have extracted the teeth that are impossible, or so we are keeping just the good ones, but they have shown us what the good ones are. They have shown us how much they can take care of themselves, so we can make much better treatment decisions. So this is very important. You cannot just go ahead and do a partial denture because they collect so much plaque, so it will fail. It's actually a better treatment to do a bridge because it collects less plaque, but it's more costly. So the healthcare challenges that we have for these patients, if you remember this very sweet lady here, are COPD. That can scare me sometimes. That's where I have needed to use oxygen a couple of times. So we need to have an oxygen, like a meter, so we know how much saturation they are under. And when I worked in the diagnostic clinic and we had a COPD patient and I asked for one, we didn't have one. But hospital dentistry has it.
A pulse oximeter?
Yeah. So if they start to fall below 94%, then you need to give slow oxygen, like 2 to 3 liters per minute, so that you get them up to 98 again. Many of the patients might not tell you that they're using oxygen at home, so that's always on alert. So we actually require everyone that we see, not that this would be legally binding or anything, but to have a physician's authorization. So we see what their physicians say, like what type of medication they are on, what type of allergies they have before we see their health history. And we take the same health history as you do here at the school. Most of them have uncontrolled hypertension, diabetes, many have uncontrolled, and we shouldn't see them, but who can say no? GERD, we see a lot of erosion. COPD, we have a lot of hypersensitivity reaction to different materials or antibiotics. So that's important because we use antibiotics more than you would at the school. And then we have the blood thinning medications, which in the beginning we were a bit more afraid of. Now I know that we can handle most things with collagen plugs, like through extractions, and we are fine.
Susanne?
Yeah.
In a lot of cases, so these patients would not have a regular medical provider, or is that uncontrolled hypertension, for example?
They might not have enough money to buy the medication. And sometimes they tell us, well, I took it this morning before I came to the clinic. So that's why I want to provide everything dental in the clinic, because they will not tell it, well, they have a doctor, but they might not have enough money to buy the medication. So what do we fight most? Well, we fight food caries. Fast progression, it can almost eat the tooth out in like 6 months. So you cannot miss it, and we often do. We often overlook it at the crown margin because it can go subgingival, and that's not where you put your explorer. So in the beginning, when we were running the clinic, the students said, well, we just need to remove the crown, and then we prep and make a new crown. I said, well, we can't do that here. Because everything that we can do with our own hands, that's like free for the clinic. That's where we should be. So I needed to teach you how to destroy a nice margin, or not so nice right now, but to destroy a margin and do a GI or maybe even an amalgam, just so that they would be able to keep that tooth. It is sometimes very difficult to do glass ionomer in these regions, just because of the gingival fluid, and it's hard to keep things dry. It's almost impossible to use rubber dam in these locations too. Glass ionomer is great, and especially if you can use it, it is great, and especially if you can give them Prevident gel, the prescription toothpaste, because the glass ionomer can take up and release fluoride the whole time. But you need to supply the fluoride in order for the glass ionomer to work like that. Its own fluoride that it has really from the start is soon released. I think within the first week. I never like to work with amalgam, but it's actually bacteriotoxic. So it's really, with this group of patients, it is okay. It's okay. I disliked amalgam so much that I'm almost quit as a dentist, just because I was so much against it. But here I kind of rethought. We do a lot of talk about diet and oral hygiene and trying to change their diet. I have here, so you can take a look at it if you want later. It is from GlaxoSmithKline's brochure that they have, but it is the best table that I have found. So I actually just stolen it and copied it. Because whatever is in red is acidic. And if you think about the roots, and if you remember from oral biology, the root starts to demineralize. That's pH 6.7. And you know, it's not that much that they can eat. So if they eat fruit the whole time, you kind of just, your teeth will just waste away. So this is really important. And what we also do, we have a lot of deep caries excavation. So we use calcium hydroxide. I use different types of liners. I use more material, I think, than you would do at school, because my goal with this clinic is to try to save teeth and not to extract them. And at school, when the elderly can pay, you can be more aggressive right away. But I can't. So root caries in elderly, usually because of plaque, and you get plaque retention because of low salivary flow. So as soon as you take up to 4 to 5 medications, it doesn't even matter what type of medications, you have compromised the signaling within the salivary gland to the extent that salivary gland secretion is at a lower level. And you don't have the cleaning effect that you normally have with flow. It has been shown that when you have an unstimulated flow, you don't even need to reach like the dry level or the xerostomia level of 0.1. At 0.16, you have caries. So root caries is the major source of tooth loss in these adults. So that's what we need to change. And here is, if you remember from oral biology, so enamel, it demineralizes at the much lower pH, 5.2, which means that we can take most foods. So when we talk about xylitol and fluoride in young adults and elderly, we talk about very different things. So if you read, you need to read studies that are aimed towards root caries or elderly or root surfaces in order to see how it will work in the elderly. So xylitol, for example, doesn't make a difference in most studies in adults. But on root surfaces in elderly, it makes a huge difference and can prevent caries. So here is one of the patients from the senior center. And we are actually doing the saliva test that you are doing in first year now. So you see she has root caries there. It almost looks like a mouse has been just eating at the cervical parts of her tooth. And you can see that the pH of her unstimulated saliva is 6.4. And the flow is 0.06. So there you have it. So then you start how can you supplement what medication usually has taken away. So that's the aim with working with elderly, just to give them more information, like how they can compensate from everything that medication, or they don't know about. Diet, for example, has removed. And you can see here that even the stimulated saliva is at a very low level, like 0.54. So here, if she's able to chew gum, which I know she is, that can help her, because then she gets her stimulated saliva, which has a lot of good buffering capacity, because you usually eat just 2 hours per day, but you have your resting saliva, the rest, like 22. So if she can chew more, if she can have her stimulated saliva in her mouth during more hours of the day, she's in much better shape. So that's the thinking behind it. Just trying to change whatever we can. I need to speed up some because I see that the clock is ticking. But here you have lots of cervical lesions. I see this especially in the Asian group, just because of their dietary habits, like the cervical caries. And I remember back in 2012, the students said, "Okay, let's extract these tooth." I said, "No, we can't," because they were saying, "Well, it goes to the pulp. I can see it." Well, I said this, so I actually found these images which shows that the pulp retracts, because the caries lesions go slowly, they don't develop in a day. So the pulp is able to retract. So this tooth is alive. So here you can see that they are there are different ways of looking at things. So working with the elderly and being faced with these different scenarios actually makes you mature as a dentist, because you need to figure out what would really be the best for the patient here and what are the alternatives, and kind of have that discussion with yourself. We see a lot of these deep caries lesions, and since our goal is not to extract teeth because we cannot replace them, we do a lot of deep caries excavations or stepwise excavations, and usually it works. Sometimes there is a discrepancy with what the x-rays say and what you see in real life. So this might be closer to the pulp than the x-ray really says. So I use a lot of calcium hydroxide, and then I put a liner that I can cure on top of it, and glass ionomer, and then you can wait up to 3 months, and then you go back and you excavate it, and you usually save the tooth. I also tend more to use a self-etching bonding system like we have started to use at the school, because here when you have lesions like that, you don't want to etch the dentin, because you know from oral biology that you open the tubules right into the pulp, and who will want to do that? So even in the elderly or even in older adults, you have a better chance of saving a tooth. I mean, it doesn't save every tooth, but it helps. Here is a scenario how one female patient looked. You see she has cervical caries on all her anterior front teeth, and that means that she's really, really dry because she shouldn't have caries there. So we are not successful with everything, and here you see the axiom. It is caries, clinical caries, that we need to work almost all of her teeth. So what happened with number 25 was that we excavated caries, and then she was still in pain. So I needed to go in and do a pulpectomy. But guess what happened? When you have two huge fillings on the mesial and distal of a tiny lower incisor, so the crown just fractured off. So there are limitations to what we can do, and I eventually needed to extract his tooth. Here is another patient, and she's Korean, and she came in. She had a pretty powerful job, and she lost her job, and she lost everything. So she had a bridge, and she was coming in and, like just putting it back, and then we looked at the bridge, and the root tips were all root tips underneath the bridge, and they were black. But she was so terrified, because especially in the Korean culture, you lose your appearance if you don't have front anteriors. So what we did, we extracted the tooth that we needed to, and then I kind of did like this and said, okay, let's put it on with Real-I-X. Because Real-I-X holds almost everything that you can keep dry when you cement it. So it didn't have much of a fit, but we were able to, I think we just cemented it once, and it lasted for half a year. And then we were saying, well, what do we do now? Because we don't have any funds. And she said that she had a flipper that one of her friends had given her. So we extracted the root tips, and then I used the flipper, and I inserted, it was one tooth that was inserted from the beginning. And then I inserted 3 more using a hard reliner, and then I did a soft reline. And then I have worked with this one and modified it according to her bone levels as they have healed. Because it takes a while after an extraction, up to a year or even longer, until the bone has fully healed. And we don't have the funds to do partial dentures more than once. We cannot do like an immediate and then change it out, because it's too costly. So we have modified this one and she has used it, so now we are ready to, and I will just find ways to give it to her because she really deserves it. Okay, I will speed up now, but these are the types of patients that we see. So what you learn when you work with low-income elderly, you need to be creative, and you will find the boundaries of dentistry because you want to give as much as you can to someone who don't have. Of course, we do the caries risk assessment, and this one, I don't know if they are really interested in this. It might just be for us to see that they are high caries risk and just kind of put that label in our mind. I used it more in the beginning. There are some recommendations. This is the hardest part, to find ways of having them change their behavior. It means almost like they need to change their heart. They need to find something that speaks to them so deeply so they can change. But it's all these preventive care products, and also you can actually rinse your mouth with water and baking soda. And baking soda has a high pH, so that will alkalize and bring so your saliva doesn't need to buffer as much if you have a low buffer capacity, for example. But these are, I actually use in faculty practice. I have many, so everything I learned from low-income elderly is useful everywhere because you get the knowledge that no one else, or very few, have. So here is a list how you can reduce caries through preventive care. You can use the once weekly rinse, the Prevident gel, the daily one, and chlorhexidine. Chlorhexidine works with high caries risk patients. You just need to have them to use it not every day because then they get these nasty brown stainings. But you can tell them to use it a week per month or every weekend, for example. Sometimes something that really works with their schedule. And I use a lot of the Arm & Hammer toothpaste. It's really hard to get, so I give it to them from the clinic. It works for a very dry mouth patient because it supplies more calcium phosphate than other toothpaste. And saliva is usually super saturated with calcium. But if you don't have saliva enough, if you're a serostomach, then this toothpaste helps with remineralization. And the baking soda in it, after brushing with it, and then I tested the pH in my mouth, I had pH 8. So that also is a great help. Well, here's just some evidence you don't need to know about. But see, just using Prevident gel, 5,000 ppm of sodium fluoride, was able to inhibit caries almost completely in compliant serostomach patients, even if they didn't have almost any flow. So the key here is the compliant. So when you work with these patients that are elderly, they might forget their appointment, you need to remind them. You need to ask them every time, what about your home care? Like, what are you doing now? And never give up on them. Change it the whole time and give them more toothpaste. See to that they really use it. If you just leave it to themselves, they might just forget. So it is like to have pedo patients, but they are a bit larger and more forgetful. So ACP, and you will hear more about this, is the amorphous calcium phosphate that you can find in toothpaste. You can find it in varnish and in profit paste. And at the senior center, even though not everyone has a dry mouth, I use only these types of products, just for the sake of the ones that are dry, because it supplements where they would need. I think even at Kaiser now, they give out the bottle of chlorhexidine to every patient that has an extraction. And I've been using it, we were using it in nursing homes in Sweden, but that's just to prevent aspiration pneumonia, because the amount of bacteria that you grow in your mouth, if you have a bad or a neglected oral hygiene, is just tremendous. So chlorhexidine helps to destabilize bacterial membranes and inhibits their uses of oxygen and the outgrowth of spores. So it's really potent. It also has a minor effect against fungus and against some viruses. So I give it out. It is per prescription, but I give it out, especially after extractions when patients come in and have huge amounts of plaque. And for the ones that have Medicaid, I write prescriptions. And I write them for one bottle with 10 refills. I don't like one, because otherwise they would run out and they would never come and ask me for a new one. So there is evidence that this is working, but of course it is effective in high carrier patients, but not in low.
Did she have time to ask some questions?
Yes.
Anybody else has questions?
Let's see here. Yeah, there are some diet and the saliva tests. And here, this is just to wake you up. No, but the pH of Seattle water is actually 8.2. So don't tell your patients, or if your patients buy water, you don't need to. So from a tooth perspective, it is much better to just use the Seattle water.
Yeah. Yeah, it's fluoridated too.
And fluoridated too.
Yeah.
Yeah, and then you have the xylitol. I was so ambitious. I was up at 4 this morning, and I thought that we would be able to cover this. Well, base prophylaxis, we give out toothbrushes, the electric ones. I don't think that these are that effective, but I think it's a good thing. They see that we care. Because these guys, they cost around $20. So they see that we really care about them. And there are some evidence. I know the school has not been promoting any toothpaste like this, but the enamel strengthening, it has been shown that it's able to prevent root caries. So everything that I've said here, there is evidence in the literature that it works. So if I end with this one, it is mainly the effects of low flow or impaired salivary gland function. And for you who took the oral biology class, this was my last slide in the salivary gland lecture too. And that's really where we are right now. Like, how do we compensate for everything, for the medications, for the diet, and for everything, for aging? Okay, any questions?
I just have a comment. That is a great slide. Yeah, that should be our basic for a starting point for our patients. So, Kim, you have a question?
Yeah, what do you use to monitor progression at the mobile clinic? Do you use photography or do you just use chart notes?
Yeah, we haven't gotten to the point yet where we can be so sophisticated. I wish, because we are, how can I say, in order to reach new patients all the time just for the grants, we need to see a number of new patients. So I actually need to tell us to stop, or tell senior services to stop and say, we just need to finish treating these patients, and then we can take new ones in. So we're not using indexes to the point where we should. And so we are not that great. We need to detect it more and then just stop it. Do you mean like initial caries, or do you mean like root caries, or?
Like, I'm just wondering about things you like monitor, things that, for example, because you were saying that you're very much into the preventive aspect of dentistry. Of course, we need to treat some things, but others we probably can monitor. So my question is, well, if we were to use, for example, I know we can't, take an x-ray over there.
Yes, we can.
Oh, you do?
Yeah.
Never mind.
We have the Nomad now every week. Or we have it there like permanently. So we use Axum and MyPass. But it's hard. That's a hard thing to be consistent And since all of you are sharing the patients, and all of us, we chart a bit differently. So what I do if I want to wait, if it is incipient caries and I want to wait and see if it really develops, and then, of course, we use silver fluoride as well, then I take the patient back in like half a year, since I have a 1 year schedule, so then we can check them up. Okay,
Thank you.
All right.
thank you.